Hello and welcome back. Myself Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to start with the thyroid gland, and today we will understand the basics of hyper and hypothyroidism. So let us begin this class without wasting any more time. So as you know that the thyroid is basically a butterfly shaped organ comprising of two lateral lobes, as we can see, one on here and another is over here, which is connected by a very thin isthmus. This is the isthmus connecting the two lateral lobes of the thyroid gland. Now, very importantly, the normal weight of the thyroid gland is around 25 gram. If you take a range, it ranges between 15 to 25 grams. So what are the cells, main cells present in the thyroid gland? We have the follicular cells and we have the parafollicular cells. The follicular cells release the hormone T3 and T4, which is essential for the brain development or CNS development, and we also have the parafollicular cells, which is responsible for secretion of calcitonin hormone. Now if you look at this basic diagram over here, so this is basically how a normal thyroid looks like under the microscope. So this is the histological feature of a normal thyroid gland. So we are reading the normal thyroid. So if you see over here, the normal thyroid, they are composed of, what are these? These are multiple thyroid follicles, and these follicles are lined by a single layer of cuboidal epithelial cells. So this is a benign thyroid follicular cell, as you can appreciate. This is the high power view. As you can see, what is this pinkish color? This is the presence of colloid inside, okay? And this is the single layer of simple cuboidal epithelium, which is indicative of thyroid follicular cells, okay? So these are the thyroid follicular cells, as we can appreciate over here. Okay. Now if you see in this diagram, I wanted to show you certain cells which are having more abundant amount of cytoplasm, which are larger as compared to the thyroid follicular cells, with nearly pale cytoplasm, okay, clear to pale cytoplasm. So this basically, yes, any guesses what are these cells? So these are the parafollicular cells. These are the parafollicular cells. These are the parafollicular cells. Now we will just have a basic understanding about the how the thyroid gland is working, how there is a regulation of the secretion of the T3 T4. So at the level, so there are three levels. The first level is the hypothalamus, then we have the pituitary, and the third level, as you can see, is the thyroid gland. So what happens that normally the hypothalamus is going to secrete the thyroid releasing hormone, which is going to act on the pituitary, and that pituitary is going to release the thyroid stimulating hormone, which is going to act on the TSH receptor present on the thyroid gland, ultimately leading to an increased secretion of the secondary messenger CAMP, leading to the formation and release of T3 T4 hormones, which is going to act on their various body sites, as we can see in this diagram. So normally, if the T3 T4 secretion is normal, then they are going to cause what is called as a normal feedback inhibition. It is going to inhibit the release of TSH and TRH once their levels are adequate. So this is the normal regulation of the secretion of the T3 T4 hormone. So with this information in our mind, we are going to discuss the basics of the thyroid gland. We will discuss hyperthyroidism and hypothyroidism. We are going to discuss what is hyperthyroidism, what are the causes, what are the clinical features, and what is the laboratory diagnosis of hyperthyroidism as well as hypothyroidism. So first we are going to begin with what is called as hyperthyroidism. Now we have to understand that thyrotoxicosis and hyperthyroidism, both of them are not the same entity. They are not synonymous, okay? So thyrotoxicosis means an increase in the level of T3 and T4, and the cause might be because of hyperfunctioning of the thyroid gland, or it might lie outside the thyroid gland, okay? So it may or may not be a hyperfunctioning thyroid gland. That is very important. Whereas in case of hyperthyroidism, basically the cause is because of hyperfunctioning of the thyroid gland. Okay, so hyperthyroidism is not the same as thyrotoxicosis, and hyperthyroidism is basically the most common cause of thyrotoxicosis. It is one of the causes of thyrotoxicosis. Now, thyrotoxicosis can have many other causes, which we will discuss later on. Okay, now again, the hyperthyroidism can be divided into primary and secondary hyperthyroidism. Now, primary hyperthyroidism is going to occur because of any problem inside the thyroid gland. So, an intrinsic thyroid abnormality. So, in that case, we will call it as primary hyperthyroidism. Whereas secondary hyperthyroidism, it will occur because of some problem either at the level of the pituitary gland or at the level of the hypothalamic gland. So what are the causes of thyrotoxicosis? Let us discuss. So it can be divided under two headings. So as I have already told you that thyrotoxicosis can be associated with either a hyper-functioning thyroid gland, that is hyperthyroidism, or it might not be associated with hyper-functioning thyroid. That is why hyperthyroidism and thyrotoxicosis are not the same entity. So the causes of thyrotoxicosis associated with a hyper-functioning thyroid gland are again can be divided as a primary and secondary. So under the primary cases, we have Graves' disease, toxic adenoma, toxic multinodular goiter, iodine-induced hyperthyroidism, and neonatal thyrotoxicosis. So these are all the primary causes of hyperthyroidism. And out of all these causes, Graves' disease, it is the most common cause of primary hyperthyroidism, accounting for 85% of the cases. Other more common causes include toxic adenoma and toxic multinodular goiter. So Graves' disease, toxic adenoma, and toxic multinodular goiter, these three entities, they are the most common cause, or they form the majority of the causes of primary hyperthyroidism. Now, the causes of secondary hyperthyroidism, as I have already explained, it lies at the level of the pituitary gland, or it lies at the level of the, hypothalamus. So, for example, if there is any kind of a TSH secreting pituitary adenoma, and secondary hyperthyroidism, it is quite rare. Now we come to the causes where it is not associated with hyperthyroidism. So there are causes of increased T3, T4 in the circulation wherein it is not because of hyperfunction of the thyroid. Instead, there is some kind of inflammation going on because of which excess amount of T3, T4 is released. So what are these conditions? Let us see. We have, number one, we have granulomatous thyroiditis, which is a painful thyroiditis and called as de Quervain's thyroiditis. Now, another kind of thyroiditis is subacute lymphocytic thyroiditis, which is a painless thyroiditis. Now, these two, they are two thyroiditis that we see, which is associated with hyperthyroidism. They are associated with hyperthyroidism. There is another kind of thyroiditis which we are going to see in hypothyroidism, which is associated with hypothyroidism, that is Hashimoto's thyroiditis. Now, other causes include struma ovary, which you will recall, it is nothing but a monodermal teratoma, which is entirely comprised of the thyroid tissue, which is secreting T3, T4, and then we have factitious thyrotoxicosis as well. So these are all the causes of thyrotoxicosis. Factitious means an exogenous intake of the thyroid hormones. Now, next we are going to understand the clinical features of hyperthyroidism. So the clinical features are because of excessive activity of the sympathetic nervous system along with raised BMR and associated changes. So the number one clinical feature that is occurring because of an increase in the basal metabolic rate. It is characterized by an increased amount of blood flow. Along with that, there is peripheral vasodilatation. This leads to a very warm, flushed skin. Along with that, because the blood flow is more, so the amount of heat loss is also more. These individuals are heat intolerant, okay? And there is an excessive amount of calorigenesis in such patients, leading to an increased sweating. And these individuals also have an increased amount of weight loss, okay? Now, the cardiac manifestations include, now before I start with the cardiac manifestations, there is an important MCQ. This is the earliest and the most consistent clinical feature of hyperthyroidism or thyrotoxicosis. Now, it is characterized by tachycardia, palpitation, cardiomegaly, arrhythmias, especially atrial fibrillation, heart failures, congestive heart failure, myofibril. Inside, if you look at the histology, you will see focal eosinophilic infiltrates, myofibril fatty change, mild fibrosis as well. There is a type of cardiomyopathy that you will see in hyperthyroidism that is called as thyrotoxic cardiomyopathy. It is nothing but it is a low output heart failure associated with left ventricular dysfunction. Now, the increased sympathetic activity that we see is associated with tremors, hyperactivity, anxiety, insomnia, that is inability to sleep. There is a proximal muscle weakness characterized by proximal muscle myopathy. Hypermotility will be there. Hypermotility as in the gastrointestinal tract, there is excessive amount of motility. There is hyperdefecation. There is a decreased transit time. And they might also have fat malabsorption. Under the ocular changes, okay, you have wide staring gaze as well as you have lid lag. So there is a wide staring gaze along with lid lag. There is a sympathetic stimulation. Now this lid lag, okay, so the upper eyelid actually it lags behind because of the sympathetic stimulation of the superior tarsal muscle, which is called as the Mueller's muscle. Along with that, there is a stimulation of levator palpebrae superioris, and because of this raises the upper eyelid. This is going to raise the upper eyelid. Okay, so this is responsible for the wide staring and the gaze along with the lid lag because of the sympathetic stimulation of the superior tarsal muscle, also called as the Mueller's muscle, and the levator palpebrae superioris, called as the LPS. Other clinical features are those which are involving the skeletal system. So there is an excessive amount of bone resorption leading to osteoporosis, and there is an increased risk of fractures. Associated, there will be atrophy of the skeletal muscles along with fatty infiltration. There is what is called as steatosis, okay, and generalized lymphoid hyperplasia and presence of lymphoid follicles. Presence of lymphoid follicles is seen in case of Graves' disease. Lymphoid follicles seen in the Graves' disease. Now, the second important clinical feature of hyperthyroidism is the presence of thyroid storm. There is an abrupt onset of hyperthyroidism in case of thyroid storm. It is most commonly seen in Graves' disease. So basically what happens, suddenly excessive amount of your T3, T4 hormones, they enter the circulation. So it occurs, and secondarily to the, because of the release of T3, T4, there will be an acute rise in the level of catecholamines. So it is basically seen in conditions associated with acute stress. For example, some kind of infection is there or surgery is there. In that situation, the patient presents with high fever, tachycardia, and if the patient doesn't receive any treatment, it may lead to cardiac arrhythmia and death. Okay. Now there is one other kind of hyperthyroidism called as apathetic hyperthyroidism. Herein you are having thyrotoxicosis in older individuals who are having various other problems as well, or various other comorbidities. So for example, there is a hyperthyroidism patient, but he might be or she might be suffering from some kidney problems or some other heart problems that is going to mask the effect of hyperthyroidism. So it is going to mask all the clinical features of thyroid excess. So the diagnosis is only made when a laboratory test is being done, and the patient will present with unexplained weight loss or worsening cardiovascular disease. Coming to the laboratory diagnosis of hyperthyroidism, very important. The classic picture is a decreased amount of TSH and increased amount of T4 hormone. And sometimes what will happen, the patients might have a decreased T4. In that case, you have to do the T3 levels, and you will see that only the T3 levels are raised, especially in such patients. It is also called as T3 toxicosis. And this is the basic clinical feature of primary hyperthyroidism. Now, if the TSH level is borderline, normal or slightly raised, along with a raised T4 level, it is indicative of secondary hyperthyroidism. Now, for confirmation, you have to carry out a TRH stimulation test wherein you are going to give exogenous TRH hormone. If there is a normal rise in the level of the TSH, it is going to exclude secondary hyperthyroidism. And once the diagnosis of hyperthyroidism is confirmed, you have to carry out a radioactive iodine uptake test. We call it as the radioactive iodine uptake test. So if there is a diffuse increase in the uptake of the radioactive iodine, it is pointing towards the diagnosis of Graves' disease. If there is an uptake in a localized or solitary area, in case of a solitary nodule, we will call it as a toxic adenoma. And if overall there is a decreased uptake, mind it, the word is decreased uptake, it is basically pointing towards an inflammatory disorder, that is thyroiditis. Very, very important from exam point of view. So with this, we have completed the discussion of hyperthyroidism. Now we are going to start with hypothyroidism. Now before we start, I just wanted to show this particular diagram that I was talking with you about a wide-eyed staring gaze. So this is occurring because of the overactivity of the sympathetic nervous system, which is going to stimulate which muscle? Which is going to stimulate certain muscle which is present in the upper eyelid, that is called as the Mueller's muscle, or also called as the superior tarsal muscle or Mueller's muscle. Along with that, there is also stimulation of the levator palpebrae superioris, which is responsible for this lid lag and a wide staring gaze. Now in case of Graves' disease also, this mechanism is there, but along with that, some other mechanism is also present in Graves' disease, which is responsible for the proptosis, which we will discuss when we will discuss the Graves' disease in detail. Now we are going to start with the hypothyroidism. Now, hypothyroidism occurs because of a structural or functional derangement that interferes with the production of thyroid hormone. Now, the prevalence of overt hypothyroidism is 0.3% and that of subclinical hypothyroidism is very high, more than 4%. Now, the most common overall cause of hypothyroidism is iodine deficiency. And the most common overall cause in iodine sufficient areas, the answer will be Hashimoto's thyroiditis. Hashimoto's thyroiditis. There is an increased prevalence with age and there's an increased incidence in women. Now, if you see over here, if you look at the hypothyroidism, just like the primary hyperthyroidism, as we had seen the hyperthyroidism. So over here also we have to understand that the hypothyroidism can be divided into two headings. It can be primary, where there is an intrinsic abnormality in the thyroid gland, or it can be secondary, wherein the cause is either the pituitary gland or the hypothalamus. So the primary hypothyroidism is more common as compared to the secondary hypothyroidism, and it can either be congenital in nature, autoimmune in nature. Under autoimmune, we have Hashimoto's thyroiditis especially, which is responsible for hypothyroidism. And if you remember the lymphocytic thyroiditis, it was hyperthyroidism. And or there can be some iatrogenic causes that is induced by the physician or because of some of the other treatment. Now first we will discuss the congenital hypothyroidism. It is most commonly due to endemic deficiency of iodine in the diet. Now the other causes of congenital hypothyroidism are, number one, you can have some inborn errors in the thyroid metabolism. That means in either of these steps, in some of these steps which is involved in the synthesis of the thyroid hormones, there is some error. And this group of disorders is called as dysharmonogenetic goiter, So this is characterized by defective iodide transport, or there can be problem at the level of organification of iodine, or at the level where there is a defective processing to form T3, T4 hormones. So in either of these steps, there might be some problem. Now the second important thing over here that can happen is thyroid agenesis. It is basically characterized by absence of the thyroid parenchyma, and then there is thyroid hypoplasia, where there is a reduced thyroid size. So these are all the important causes: dysharmonogenetic goiter, thyroid agenesis and hypoplasia. All of them can lead to what is called as a congenital hypothyroidism. Now there is an entity which is called as autoimmune hypothyroidism. Now this is the most common cause of hypothyroidism in iodine sufficient areas of the world. Then the most common cause, or the vast majority of cause, is due to Hashimoto's thyroiditis. Now the diagnosis, since it is an autoimmune disorder, the diagnosis is made by the presence of certain autoantibodies. For example, autoantibodies against antimicrosomal autoantibody or anti-thyroid peroxidase called as anti-TPO. Okay, anti-thyroglobulin antibodies. So these are the three kind of important autoantibodies that you will see in such patients. Clinically very important, they show symmetric enlargement and it's a diffuse enlargement of the thyroid gland. So symmetric diffuse enlargement of the thyroid gland is seen. Now this autoimmune hypothyroidism can either present alone or in combination with autoimmune polyendocrine syndrome type 1 and 2. Thirdly, we are having iatrogenic hypothyroidism, where it occurs because of some surgical procedure or radiation-induced ablation has been done. Why it has been done? As a treatment of hyperthyroidism or for managing any primary neoplasm of the thyroid. Certain drugs also can cause hypothyroidism. Now, drugs that are used in the treatment of hyperthyroid conditions, for example, thionamides like methimazole and propylthiouracil, they can cause excessive use of this drug can cause iatrogenic hypothyroidism, and sometimes there are other drugs which are used in non-thyroid conditions like lithium and para-aminosalicylate acid. They can also lead to reduced thyroid secretion, leading to iatrogenic hypothyroidism. Now, secondary hypothyroidism, if we see, it can that is also called as the central hypothyroidism. Again, it can be because of two reasons. Either some problem is there at the level of the pituitary or some problem is there at the level of the hypothalamus. So, problem at the level of the pituitary includes the pituitary tumors or trauma, and at the level of the hypothalamus it includes because of some hypothalamic tumors or trauma or some kind of radiation. Now, clinical features of hypothyroidism, it depends on the age at which it presents. So, it is called as cretinism if the hypothyroidism is involved in the infancy and in the childhood. It is characterized by severe intellectual disability, short stature, very important, these terms are very important. There is a short stature, coarse facial features, very important, protruding tongue and pot belly. Sometimes they will show umbilical hernia as well. And if the hypothyroidism involves adults, it is called as myxedema. So, hypothyroidism in older children and adults is called as myxedema. Now, there is a slowing of the physical and the mental activity. The speech and intellectual function is also reduced. These individuals are cold intolerant, they are overweight and they are constipated. So, these features are quite opposite to those that we had seen in hyperthyroidism. Now, very important feature of patients of hypothyroidism is an altered lipid profile. There is an increased amount of total cholesterol and LDL lipid, and this increases the risk of atherosclerosis, leading to an increased cardiovascular mortality. Accumulation of the matrix substances is there, for example, glycosaminoglycans and hyaluronic acid, where in the skin as well as the subcutaneous tissue, and this is responsible for what is called as a non-pitting edema. Now, again, these individuals have coarse facial features, enlargement of the tongue with deepening of the voice. Females have menorrhagia, amenorrhea or oligomenorrhea, and there is an increased diastolic blood pressure in such individuals with bradycardia. Coming to the laboratory diagnosis of hypothyroidism, so it is very simple. An increased TSH with a decreased T4 will lead to primary hypothyroidism diagnosis. A decreased TSH with decreased T4 will lead to secondary hypothyroidism diagnosis. Now remember, in any kind of hypothyroidism, the T4 level will always be low. Okay. Now, to end, the last important point that I will say and then end is the genetic cause of hypothyroidism. Sometimes there is a mutation in the SLC26A4 gene. Now, this gene normally encodes a pendrin anion transporter which is present in the thyroid and inner ear epithelium. Now, because of mutation in this particular gene, it can lead to hypothyroidism along with sensory neural deafness, and this combination of features is called as Pendred syndrome. So, with this discussion, we have completed the basics of hyper and hypothyroidism. Thank you very much for watching this particular video.